Hi, I'm Dr. Jack West, medical oncologist from Swedish Cancer Institute in Seattle, Washington, and I'm also the founder and president of GRACE, Global Resource for Advancing Cancer Education. And I'm happy to be here for a post-ASCO 2017 update with two of my colleagues. With me is Dr. Matt Gubens, who is Associate Professor in Medical Oncology, Specialist in Thoracic Oncology at the University of California, San Francisco, and Dr. Jyoti Patel, who is Professor in Medical Oncology at the University of Chicago, in Chicago. Thanks for joining us.
Thank you.
Thanks for having us.
So we're going to talk about some of the newer developments in the field, and there have been some big changes. Let's start with targeted therapies. One of the biggest and most anticipated studies was called ALK, a direct comparison for patients with ALK-positive non-small cell lung cancer, advanced disease, about 4 or 5% of patients. And historically, the standard in first-line treatment has been an oral therapy called Xalkori or crizotinib. And that's a first-generation ALK inhibitor with activity that's pretty good and better than chemo, we know, but may not be as good as some of the later second-generation ALK inhibitors. One of those is an agent called Alecensa or alectinib. And we saw in this study a direct comparison of alectinib versus crizotinib, or Alecensa versus Xalkori, in these previously untreated patients. Huge difference in progression-free survival, but also some differences in activity in the brain and other things. What do you think is the significance of this trial in clinical practice, starting with Jyoti?
This will change how we approach the subset of patients. So we know that many patients with ALK translocated lung cancer are destined to see multiple therapies over time, and we're always looking to improve survival. Certainly crizotinib or Xalkori has been the standard of care, and it's a really great drug, but we know that the majority of patients will become resistant to the drug within a year or so. So this newer drug, alectinib, has been tested in patients who've already received crizotinib and showed really great activity in the brain, really good tolerability, and really good disease control correlated to better overall survival. This study confirms something we heard about a year ago. The study, patients were randomized to either get the crizotinib or alectinib, and it's a similar study that had been conducted in Japan, but both of them demonstrated almost a doubling, over a doubling of the time until the cancer grew to progression-free survival. And certainly that's very exciting, right? So we know that by dropping the likelihood that the cancer will grow, we think that's correlates to better survival. What's really exciting about this class of these newer drugs is that there's penetration into the brain. Unfortunately, many patients with ALK translocated lung cancer will develop CNS metastasis. This drug in particular has significant activity in the CNS.
In the central nervous system.
In the central nervous system, sorry, within the brain. And so patients can stay on this medicine without side effects, without toxicity, and really see better survival. So this will come up into frontline treatment, or the initial therapy patients receive. And my practice pattern will certainly change, and how I advise patients will change.
Yeah. One difference, the J-ALEX, the Japanese trial that was very similar in structure to Japanese only, used a different lower dose of Alecensa alectinib. Major difference also with lower side effects in the Japanese trial. Not a big difference here, and it's not to say that this is a non-toxic therapy, but generally very well tolerated in patients who are, we hope, going to be on this for years rather than just weeks to months, as some of our treatments have been. Matt, what are your thoughts? I know you see a lot of these patients with driver mutations, more common in never smokers, so you and I see a lot of these patients in our clinic.
Just to take a step back, as exciting as Xalkori was to really kind of help us have a new kind of treatment for a target that we had just identified a few years ago, Xalkori was a drug off the shelf. It wasn't designed meaningfully to be an ALK inhibitor. It's kind of almost an accident. And so what's kind of been exciting about the development in this field is that these next generation drugs, like Alecensa, really were purposely designed to hit ALK better and hit the brain better. And as a result, these studies are really showing us this tremendously improved time to progression, benefit in the brain, and then also, really importantly, tolerability. Xalkori is a great drug, better than chemo for almost everybody, but it really does become a drag as you take this pill every day for hopefully months. For this drug, that for the average patient on study, they'll be taking for 2 years and beyond, which is just a remarkable milestone. It's much more tolerable. So I think those two things really stick in my mind as just emphasizing how practice-changing this is.
We should mention that there are other later ALK inhibitors that's a crowded field where we have the enviable dilemma of how to potentially sequence them and whether there's still activity of some similar drugs after patients eventually progress on this first line. But fortunately, we're going to have years to be working on these questions as more and more patients do well for years on this therapy.